everybody, and welcome to the Student Success Review session on trauma, traumatic brain injury, and spinal cord injury. And when we talk about any kind of trauma, I know that you understand about the primary and secondary assessment, but the other consideration with trauma is the consideration of triage. And that's which patients do we see first and which patients are not necessarily viable. And so there's some triage practice questions or prioritization practice questions that I encourage you to do, and these can be found in that Silvestri NCLEX review book. We talk about some general information about trauma, whereas energy cannot be created or destroyed, only changed. In other words, the patients will come into the emergency department after some kind of traumatic injury, and it's really best if you can get some information from other sources, such as the paramedics that picked them up or maybe some other individuals who witnessed the scene of the accident, because some people will look pretty good, but in fact they have been injured fairly badly, and that's because complications of edema will expand the injury, and that can occur hours or a day later. And that's where I likened edema to that bud that became a flower. It does get worse over time. Comorbidities such as diabetes and heart disease, they place the patient at further risk. When we talk about injuries or mechanism of injuries, we kind of have this cutesy little saying that solid structures crack, and there's a listing of solid structures that can crack and therefore bleed. We've got a severely beaten patient who presents with periorbital and postauricular ecchymosis. This finding indicates a fracture of what? And hopefully this was very easy for you. The fracture of the skull bones will show signs of what's known as raccoon eyes or periorbital edema, and postauricular ecchymosis is known as battle signs. And that's because the skull is composed of a lot of bones. Bones are very vascular, and so when these bony structures break, then the blood from the bone vessels will kind of leach out into the surrounding tissues. A severely beaten patient presents with periorbital and postauricular ecchymosis. In addition, the nurse notes a clear nasal drainage. To determine the presence of cerebrospinal fluid rhinorrhea, the nurse will first. Well, first off, this is clear nasal discharge. So we're not going to do a halo test. That is only done when it's a bloody discharge. What we will do is we will evaluate the clear discharge for glucose, because if this is truly a nasal discharge from some kind of sinus issue, the CSS or the glucose will not be positive. If this is truly CSS from a CSF leak, then the glucose will be positive. Again, a halo test is only done on a bloody drainage that's coming from the ears and or nose that is a suspicion for a CSF leak. A patient who suffered a blunt force injury to the side of the head, the temporal region, is diagnosed with an epidural hematoma. Identify which description matches the diagnosis. So what is the typical mechanism of injury for or the signs and symptoms, presenting signs and symptoms for an epidural hematoma? For an epidural hematoma, the individual will have an immediate unconsciousness at the scene usually, and then they will followed by an alertness that's then followed by a decrease in level of consciousness. If it's a venous disorder, then the level of consciousness will just kind of decrease and they'll complain of a headache. So this is very, very typical, this epidural hematoma, of an unconsciousness that is followed by alertness. If it is a subdural hematoma, then it is a decreasing level of consciousness and complaints of a headache. A patient was admitted via the emergency department after an automobile collision in which his forehead struck the windshield. In this situation, the contrecoup injury would occur where? All right, so then it's important for you to identify what does it mean to have contrecoup. Well, contrecoup means opposite. So if you look at an individual, the forehead is in the front, so that's going to be the frontal part of the brain, and then the opposite would be the back or the occipital region. So the contra-coup injury is going to be the occipital, that's the opposite, and the coup injury or the direct injury from striking the windshield would be the frontal injury. A patient with a traumatic brain injury exhibits signs and symptoms of increased intracranial pressure. So, which is the priority nursing intervention for ICP reduction? Well, what are we talking about here? We are talking about the eights of ICP management, and the eights of ICP management include elevate the patient's head of the bed to at least 30 to 45 degrees. Yes, hourly neurologic examinations is a correct answer, but it does not answer what you're being asked about. It is not a nursing intervention for ICP reduction. It is a nursing assessment for the determination of whether a patient has rising ICP. So this is what is so commonly found on nursing exams, this trickery, where it's really a correct answer, it's correct information, but it's not answering what the question is asking. So you have to watch out for that. Of course, we wouldn't ever want to give a hypotonic solution. High flow oxygen is not needed. There is nothing that says that this patient is having an oxygenation issue. A motorcycle rider's chest was thrown against his handlebars during a high-speed riding accident. So which assessment findings suggest a flailed chest? Well, let's first determine what is a flailed chest. And a flailed chest is defined as two fractures per rib in two or more ribs or a detached sternum. So what this is definitely a problem with the mechanics of breathing because the individual cannot properly inhale and or exhale. So inhalation is severely compromised. So what paradoxical breathing is, and that's the answer, that is the sinus symptom that indicates a flailed chest is paradoxical breathing. And what that means is opposite than what should normally occur. If you breathe in, you would see that when you breathe in, your abdomen is kind of puffed out, whereas with paradoxical breathing, it is opposite, so it is abnormal. So your chest is sucked inward with breathing, and it should be sucked outward with inhalation. And then the opposite's going to occur with exhalation. So again, this kind of gets confusing, but the bottom line is flailed chest, paradoxical movement of the chest wall is a clear indication of a flailed chest. A patient who fell 40 feet arrives in the ICU on mechanical ventilation. 2 hours after arrival, the critical care nurse notes a distinct Rice Krispie sensation on chest palpation. The surgeon is notified because the nurse suspects what? Well, the answer to that is a bronchial tear. So bubble wrap or Rice Krispie sensation on palpation indicates air in the subcutaneous tissue. We were first introduced to this. It was known as subcutaneous air or subcutaneous emphysema. And one of the things I just want you to remember is that it indicates some kind of air leak within the thoracic area. Usually it's a pneumothorax. Now in this instance, because the patient fell so many feet, 40 feet is around 4 stories. That's a pretty long fall. And so we know that this could put a patient at risk for cervical cord compromise. Sure, it could, but there's nothing in the scenario that leads us or gives us the signs and symptoms of a cervical cord compromise. If it was that, then the patient would have a problem such as decreased movement or sensation. What about esophageal intubation? Well, again, it is hoped that the healthcare team is competent enough to where if they put the patient into a tracheal tube in the patient, they would have absolutely auscultated breath sounds right away. And since this is a 2 hour later, a patient who was intubated in the esophagus, they wouldn't have survived that long. And then intrathoracic bleeding, what kind of clues would I have given you if I wanted to steer you in the direction of a bleeding scenario? And the answer to that would have been something along the lines of a rapid pulse versus a somewhat decreased blood pressure. And that's would have been the scenario for that. So what I'm trying to get at is look at your clues, because Dr. Reed will provide some assessments, adjectives on your patients, and anytime there is diminished breath sounds or unequal breath sounds, then you have to say that this is a respiratory problem, and the Rice Krispies or the emphysema, subcutaneous emphysema, it kind of all stems into a respiratory problem. So this is a bronchial tear. And that leads us to our next trick, or our next thought, is that whenever there is a fixed points tear on our mechanism of injury. In other words, whenever patients fall, you can have tear the aorta, tear these ureters, tear the bronchial tubes, skin, and the nerves and the neurons in the head. A 20-year-old was kicked in the anterior chest by a horse. He's alert with no complaints of dyspnea. SpO2 is 100% on room air. Respiratory rate of 16. Blood pressure is 120/70. The heart rate's 88. So what priority nursing intervention is needed next? And the answer to this is, when you do ABC, we are on the C category. We've got the respiratory rate of 16, and we've got the SpO2 of 16, and he's not dyspneic, so we've assessed his respiratory pattern. So our next thought is about the cardiac. And so why would we put him on a cardiac monitor? We do have his blood pressure and heart rate, but why a cardiac monitor? Well, he's kicked in the anterior chest. And what's the anterior chest? Well, this is a blunt force injury to the heart, and the right ventricle is at risk because of the way the heart is kind of laid out inside the chest. So that's what should be considered. So what other nursing thoughts would you suspect if there was a myocardial injury? Well, you have to think that perhaps on the EKG there would be ST elevation, because again, any kind of myocardial injury that could cause ischemia or injury can have ST elevation or ST depression. And if this was an injury where there were myocardial death or myocardial cell death, then we would know that we would also check the troponin levels. So these are all things that would be assessed if this was a myocardial or blunt force injury to the heart. Now, one of the things I do want to point out, especially to those of you who are heading into the OB realm, is that if this was a female, the fact that, or the thought of collecting a urine specimen is a consideration. Why? Because any kind of traumatic injured patient is going to have x-rays, and any female that walks in that is within childbearing years is considered pregnant until proven otherwise. A patient involved in a head-on collision has an abdominal wall contusion at the level of the lap belt. Based on this observation, the trauma nurse will assess the patient for potential. Well, again, this is about the clues on the scenario, and of course, the scenario read that it's the lap belt. So if we're looking at the lap belt, we know that the lap belt goes across the abdomen, so we're concerned about a bowel rupture. So that pretty much ruled out, with the lap belt, would have ruled out anything in the chest. So that's rib and thoracic are ruled out. Now, if I had said it was the chest seat belt that went across the chest, then A and B could have been an option. But because we specifically said lap belt, then you have to think, where is the lap belt? And it's over the abdomen. Now, why not the renal contusion? Well, the kidneys lie in an area that is known as retroperitoneal. In other words, it's behind the abdominal space. So the kidneys are usually not a problem from a frontal injury. Kidneys are going to be a problem when it's an individual who falls from a fairly great height and then lands on their feet or something of that nature. This again is another reminder on our mechanism of injuries that hollow structures pop. That's why your mama always told you be sure and wear clean underwear and empty your bladder before you get in your car, because you want to make sure that your bladder is not full if you're in a car accident. And of course, there's some nice visual images here of some hollow structures that can pop. Assessment of a patient with a hepatic laceration includes serial abdominal examinations and hemoglobin level measurements. What additional serial diagnostic studies would be relevant? And the answer to this question is ALT and coagulation studies. This patients with liver problems, we would of course look at liver enzymes, that's ALT, and we know that the liver is responsible also for providing or making the clotting factors, so we would want to look for coagulation studies. The liver is a very vascular organ. A lot of blood flows in and through the liver, and patients with liver lacerations or liver damage, they really do bleed a lot. So it is very important to assess for signs and symptoms of hemorrhage. A woman in a bar fight sustained a blow to the epigastrium, which findings suggest a pancreatic injury. A pancreatic injury is indicated with an elevated amylase and lipase level. Amylase and lipase are pancreatic enzymes, and so when they're elevated, that is an indication of a pancreatic injury. A patient has sustained a fractured femur. The patient's now complaining of excruciating pain that is not controlled with increased analgesic doses. The patient has a pedal pulse and is able to wiggle her toes. The trauma nurse suspects that compartment syndrome because And the trauma nurse knows that compartment syndrome, a key part or a key characteristic of compartment syndromes, is that it can be present if the patient has a distal palpable pulse. So let's talk about compartment syndrome to make sure that you understand. It usually occurs with crush injuries, or it can occur with lower extremity fractures. So anything that can cause edema. So let's pretend that the patient had, let's do the scenario. A patient had a fractured femur. We know that edema immediately occurs, and then like our little flower scenario, it will blossom and bloom and get bigger. And of course, as soon as edema occurs, then what can happen is that edema and that increased presence or increased amount of space that the cells take up in the leg can cause compression on some other cells that weren't edematous, and then this can cause even more edema. What can happen then with a lot of edema is that it can compromise venous return, and so you have this venous blood that is trapped in the area and becomes congested, which leads to, again, more stuff taking up space that shouldn't be there, and then that will increase the edema even more. And so now, as all of this stuff is just expanding and expanding and expanding, the edema then starts infringing on arterial blood flow, and that is what is compartment syndrome. When arterial blood flow has the potential to be or is actually compromised. And so that's where you go with those P's. That's the pain, pallor, paresthesia, poikilothermia, and pulselessness. And a compartment syndrome initial is those patients who have pain that is out of proportion. In other words, whose is not controlled by pain medication administration when it was or used to be controlled. And then again, if you have pallor or poikilothermia, a lot of swell. Notice that paralysis and pulselessness are late and ominous signs. These patients, if there is not an intervention that is done, these patients can lose their limb. A person's leg was pinned under the car for several hours and now has compartment syndrome. The trauma nurse identifies dark tea-colored urine as a sign of Dark tea color urine is a sign of myoglobinuria. So let's look at the scenario. We see that the leg was pinned under a car. This is a crush injury that has now caused compartment syndrome. That means that muscle damage in the leg has occurred. And when muscle is damaged, then the muscle that's damaged releases myoglobin. And myoglobin is a very large protein molecule that once it's released, then it gets drawn into the blood space and then it travels to the kidney. And it can actually cause intrarenal AKI. A sign and symptom of myoglobinuria is dark tea-colored or amber-colored urine. And of course, it's all about listening or looking at the scenario, because compartment syndrome and a crush injury was your clue that this patient had a muscle injury, plus which means that rhabdomyolysis occurred, and that means that myoglobin's been released in the blood and has gone through the kidney. What's the treatment? Well, the treatment is lots and lots of fluids. As a result of a motor vehicle crash, which occurred 48 hours ago, a patient has sustained a left femur fracture. Upon assessment, the ICU nurse notes that the patient is now restless, they're diaphoretic, respiratory rate is 32 breaths per minute, and they're complaining of dyspnea. Which additional findings would cause the nurse to suspect fat embolism syndrome? And the answer to that is petechiae, that is found on the chest, neck, and conjunctiva, so that's in the eyes. So what are the complications of any traumatic injury that essentially results in the immobilization of the patient? Well, we have compartment syndrome, and we have fat embolism, and of course the old standby DVT. So these are the things that can occur with immobilization. Each one has some unique signs and symptoms, and those are the things that you need to know. Fat embolism signs and symptoms are unique, petechiae, and neck and conjunctiva petechiae. A patient involved in a motor vehicle collision presents with complete loss of movement and sensation below the clavicles. The priority nursing intervention is to monitor the patient for signs of, well, hopefully you didn't fall in the trap and pick either neurogenic or spinal shock. These are both good answers. They do occur with a individual who has some kind of spinal cord injury, but they are not the priority intervention. Remember that priority nursing intervention brings to mind ABC, so sing those ABCs and think airway, breathing, and circulation. What comes to mind with airway? Well, nothing that's listed here. What comes to mind with breathing? Well, that's answer B, hypercarbia, because any patient with any kind of cervical spinal injury will or can have respiratory compromise. Now, where in the scenario did it say cervical spine? Well, it didn't. But it says that the patient has a complete loss of movement and sensation below the clavicles. That's pretty high up. And that usually indicates either a high thoracic or a cervical spine injury. And any patient really with a cervical spine injury should be assessed for some kind of respiratory compromise. Why? Because of our blossoming flower. Because whenever there's swelling, even if it's in T in the first thoracic, you've got to consider with swelling, it can infringe upon the cervical spinal cord, and so we have a respiratory compromise. Now, can neurogenic shock and spinal shock occur? Of course it can, absolutely, but that's not going to be your priority. Your priority is going to be airway and then breathing, and so that is hypercarbia, which is another term for hypercapnia, that's CO2 retention. As a result of a motor vehicle crash, a patient has sustained a cervical spinal cord injury, which assessment finding by the nurse would indicate that the patient is experiencing spinal shock. Select all that apply. The answer to this question is A, B, D, and E. So you're going to have to know spinal shock versus neurogenic shock. And I kind of keep them separated by thinking, well, with spinal shock, that has to do with muscle. And so these patients will get initial muscle flaccidity followed by muscle rigidity or spasms, and then other causes will be bladder dysfunction, absence of sensation below the level of the injury, diminished reflexes, and flaccidity. So these are the things that occur with any kind of spinal cord injury. Any kind of spinal cord injury can have spinal shock. Neurogenic shock, which really the answer to, if I had asked you this same question but instead put neurogenic shock, that would have been answers C and E. That's really about vascular signs and symptoms, where you have a decreasing heart rate, a bradycardia that can cause a lower cardiac output and therefore a lower blood pressure. And it is because of the loss of the sympathetic nervous system and the control by the parasympathetic nervous system. So you have systemic vasodilation. If this seems like a whole bunch of information, there is no doubt that it is, so just write down the signs and symptoms of spinal shock versus neurogenic shock on your exam sheet. A patient acquired a C7 spinal cord injury after a diving accident. During the morning assessment, the nurse notes that the patient is diaphoretic with a flushed face and neck. He's complaining of a severe headache, blurred vision, stuffy nose. After finding the blood pressure markedly elevated, which action should the nurse take next? Now, I'm going to tell you that I am not a neuro nurse and I don't like neuro. So I actually saw this question somewhere. I reworded it a little bit, and then I put this here in our practice questions, and I got it wrong. So what do we do first? Well, we sit this patient upright with the legs dangling, and that seems like an odd answer option, but here's the story. What do the signs and symptoms indicate? What does the injury indicate? So we have a spinal cord injury, and it's a cervical spinal cord injury, and all individuals from T6 on up, so that would be T6, 5, 4, 3, 2, 1, and any cervical spinal cord injury are at risk for not only neurogenic shock, but a problem called autonomic dysreflexia, and that's what these signs and symptoms indicate. This patient has autonomic dysreflexia, and what that is this is a poor communication between what's happening down below the injury and what the brain is experiencing. So that is why there is such weird signs and symptoms. You have vasodilation from the level of the injury upwards. So if it's a C7, that's why the face and neck is flushed and diaphoresis is occurring above the level of the injury. And because of this vasodilation, that is the cause of the blurred vision, stuffy nose, and headache. And then kind of down below the injury, which is where the heart is, you will get bradycardia and you will get a markedly elevated blood pressure. And so this is the problem, is that these individuals will have such a high blood pressure, they are at risk for stroke. And so you've got to get that blood pressure down. And so how do you do that? Well, you sit the patient upright and you dangle their legs. Now, what is the cause for this whole scenario to begin with? Well, the cause for the whole scenario, and this kind of slide tells you, is that it can be anything. You've got bladder distension, bowel with constipation, you've got pressure ulcers or tight clothing. So there's all kinds of causes that kind of stimulate the response to begin with, and that has to be fixed, but you've got to get that blood pressure down first. So here it is, call for assistance, sit upright, lower legs, and then you're going to do all those other things that you were thinking of, which is get rid of the problem that caused the autonomic dysreflexia in the first place. I found this on the autonomic dysreflexia site. I think it's a fascinating and fabulously put together piece of paper. And so anyway, the point is you've got to know this. And so I would just write this down on your exam sheet. If you have questions, email me. I hope this presentation has been helpful.